Hello and welcome to Other Voices, brought to you by Peninsula Peace and Justice Center. I'm your host, Paul George. Proposals for a Medicare for all single-payer healthcare system are gathering a lot of attention as the major debates in next year's presidential elections start to take form. For this edition of Other Voices, we'll take a thorough look at what Medicare for all means. How does it work? How would it be implemented? And what are the chances that it will actually become national law? Helping us understand this complex issue are two people who really know the ins and outs about Medicare for all. Seated to my right is Michael Lighty. He is considered a preeminent spokesperson and expert on Medicare for all for over 25 years. Michael has organized, written, and spoken on the subject. He is a fellow at the Sanders Institute and serves on the board of the Martin Luther King Jr. Freedom Center in Oakland. Michael, welcome to Other Voices.
Thanks a lot, Paul. Great to be here.
Thank you for coming down. And Salem Ajluni is a member of the Santa Clara County Single Payer Healthcare Coalition and the Democratic Socialists of America. Salem studied and taught economics for more than 2 decades before joining the United Nations in 1996, where he worked as an economic analyst and consultant. Salem, welcome to Other Voices.
Wonderful to be with you.
So I like when people are coming from organizations to give them a minute or two to just tell people what your organizations do. The Sanders Institute, this is Bernie Sanders, right?
Yeah, well, it started by his wife, Jane, as an institute where you could engage people in a unique kind of integrated approach to public policy and then put forward these ideas through civil discourse. And so its most prominent event was a gathering done in the first part of December, and I spoke there with Robert Poland, and who had done a special study on the economics of Medicare for All, and we presented that to the gathering. And there's a video, What's really extraordinary is the breaking down of silos. So there was a workshop on housing policy that brought in people from Barcelona and Los Angeles.
Interesting. Yeah. So they do a lot of these public forums.
Well, so that's what they're trying to do, is then replicate that, in different areas around the country. We suspended the Institute for the campaign, perceptions being what they are.
Yes.
So we'll see.
Yeah, all right.
Yeah, I'm with the Santa Clara County Single Payer Healthcare Coalition. It's about a 15-year-old organization. We're involved in...
that alone tells us something about this,
yeah,
this struggle,
it has a very
well,
this is a decades long.
There's that.
We engage in public advocacy at numerous levels, including door-to-door canvassing for Medicare for All, tabling at farmers markets, public locations, public venues, writing, organizing others. And our aim is ultimately to get. We worked on the Healthy California campaign in 2017, 2018 quite intensively, which was the California state version of Medicare for All. Michael, of course, was a point person.
In Sacramento.
It was in Sacramento, exactly. 562. Yeah, the Senate Bill 562, which ultimately didn't win, but we were actively involved in that most recently, and that's actually when I started getting engaged. It was about 2.5 years ago with this organization.
Yeah. Speaking of the longevity of the struggle, I'll just mention that I worked for the Single Payer Ballot Initiative.
Oh, yeah.
Back in 1994. So
wow.
That's right.
This is a long time, and we got clobbered, and I'm going to ask you about that. Let's start by, I'm sure everybody knows what's wrong with our healthcare system, but let's just start with a quick overview. What are we fixing here before we get around to the discussion of how we're going to fix it?
People don't get the care they need when they need it. The present system rations care based on ability to pay. We've got private insurers who are playing a middleman role that's inefficient, wasteful, and frankly denies people the care they need. And as a result, we have 20 million uninsured, and we have another 40 million probably Americans who are underinsured, who basically have a deductible so high they can't use their health insurance. So what we're fixing is we're eliminating the barriers to care, we're guaranteeing health care for everyone, and we're eliminating those out-of-pocket expenses that are barriers.
And taking the profits out, which is
yes.
part of why we're so expensive. Do you want to add anything to that, Sal?
I see the Medicare for All struggle as basically taking something for which we have proof of concept, and that is Medicare. It's a system that's been around since 1965-66, works very well, has popular support, is the most popular insurance program in the country amongst, if you compare it to private and other ACA insurance policies or coverages, the Medicare comes out on top in terms of its approval rating amongst its users. So we're taking that proof of concept, what we're trying to do, and scaling it, basically. So I'm using Silicon Valley tech language. We've already got the proof of concept, and it's been there for 50 years now, more than 50 years, 55 years, and it works well, and it's relatively efficient, and equitable,
and it's
relatively
been
inexpensive.
And amended, because we learn as we go along.
It has been amended over time, and what this would do is basically expand that to everybody. Don't cut the age off or start the age 65. Reduce the age to 0, basically, to day 1.
Yeah.
And
But really, I think the key part, though, is that we're improving the benefits that Medicare provides, right? We're expanding those benefits so that it includes hearing, dental, vision, other things.
Long-term care.
Long-term care that it hasn't. But also, Medicare itself has been severely privatized. You've got all sorts of insurance products as part of Medicare. And so we need to unwind that as well, because those are functioning as barriers to care and profit-making centers that shift dollars away from patient care to the profits and exec salaries of the insurers. And that's happening within Medicare, too.
You're talking about Medicare Advantage.
Medicare Advantage, the Part B plans, the drug plans under Part D, all of those are private entities. And so we have to unwind that, too.
Well, let's talk about that a little bit. Let's get into Medicare for all, and that's a good place to start, Michael. I am old enough to be on Medicare, and Social Security takes something out of my Social Security check each month, but I'm also sending a check to Kaiser every month for that Medicare Advantage. What happens with that? Because there are a lot of people in my same situation. I'm pretty happy with Kaiser, quite frankly.
Right.
So tell me what's going to happen to my plan.
Well, nothing. Really, I mean, essentially nothing, because what happens is, what you do with Medicare for All is the same benefits and advantages you get through what's Senior Advantage and Kaiser, you get for everybody. Right now, you have to go into a Kaiser Medicare Advantage plan, and then you can only go to Kaiser doctors, right? And then Kaiser is getting an additional payment from the federal government to cover you. If you were in regular Medicare, they would be cost less for the federal government. In Medicare Advantage, it costs the federal government more. So these are HMO plans within Medicare, and they're highly profitable. They're the growth center. When you hear private insurance executives, like the former CEO of Aetna, say we need a public-private partnership, what they're talking about are these Medicare Advantage plans, because they're so profitable for the insurance companies. They get the spiff from the feds, and they get premiums.
They get the what from the feds?
The spiff, a little extra, a little extra on top, And so that's how they make their money, and it's the biggest growth area for the private insurance companies, and our taxes are paying for them. So what we do with Medicare for All is we say, no, we don't want that narrow network. Sure, if you want Kaiser, go into Kaiser, but you can also leave Kaiser. And you don't have to go into those plans in order to get the vision and the dental and the hearing coverage and the drug benefits. You don't have to do that. You get it all in one plan through this expanded Medicare.
I use Kaiser through the ACA. Right? That's the insurance that I have. And basically what it would
I had it through ACA too before that.
And just what it would mean is just I use my card. I go to Kaiser, go anywhere else, and I can get long-term care and vision and dental. Dental I have to pay. Actually, dental, I get my dental when I go out of the country, right? That's where I seek my dental services. It's always outside of the country because it's much less expensive and it's very good quality. And rather than paying, really, the insurance policies that they give you for dentistry around here are foolish. I mean, you pay a premium, but it doesn't cover anything, right? It doesn't cover anything that you need. Exactly. So this would basically give me the freedom to go to anywhere I want to go in terms of seeking services, seeking providers, whether it's Kaiser or Stanford or the Santa Clara Valley Medical Center, and all on one card. And it would be paid by a central single payer, one payer. Generally, which would be Health and Human Services, right? HHS, or CMS.
Yeah, it sets up a new CMS. Medicare, trust fund.
Right.
And it has dedicated revenues, and we were able to negotiate rates, set prices. We estimate drug prices go down 40%. And just as you say, right, everyone can go to whatever provider of their choice. I'm always amazed. You always hear about choice, competition, and innovation in the present system, right? When in fact the present system doesn't really offer any of that, right? They tell you what doctor to go to. They tell you how long you can be in the hospital. They tell you what prescription you can get, right? And so they're out there regulating our behavior, whereas prices skyrocket. The rest of the world, they regulate prices, and behavior. What you do is you get the healthcare you need, not figure out what doctor you can go to and what plan is going to cover you.
So why isn't regulating prices sufficient?
Regulating prices works if you're not wasting money through profit taking, through executive salaries, through shareholder dividends. Think of it this way: the CEO of United Health made $66 million in 2017. $66 million. They made was over $12 billion in 2 years under the ACA. So you can't just regulate prices. You've got to take that money that's being wasted and apply it to patient care.
Right. I would just add, I'm an economist, and what we're talking about is the Medicare system having monopsony power, right? The sort of monopsony power that currently, let's say, a Walmart has when it decides to.
Define monopsony.
A monopsony is buying power, right? It's buying power. Monopoly is selling power, and monopsony is buying power. And what Medicare currently has, to some extent, and the VA has to even a greater extent, is the ability to use its monopsony power vis-a-vis drug companies to negotiate prices which are 40% below for the VA than they are for Medicare. Medicare's hands are tied by the Towson bill of 2004-2005, right? They tied the hands of this Part D of Medicare. Medicare cannot negotiate prices. Well, what we're saying is you give the same sort of monopsony power that Walmart has when it's buying detergent for its many stores around the country, right? Laundry detergent, to the federal government, a federal government public entity, when engaging with drug companies and when engaging with medical service providers, you get reduced rates. They're not going to go out of business. You're going to offer them a price that allows them, of course, to exist and to persist, but they're not going to have these excess profits that Michael's talking about, where they can pay a CEO $66 million or pay their stockholders billions in dividends in profits, at the expense of people who should be receiving better and more care, basically.
See, I think, Paul, the key point is, for a patient, things don't change, except no longer do you have to worry about whether you have the $20 for a prescription, or you no longer have a $1,500 deductible, because the deductibles are gone, the copays are eliminated, you're no longer paying insurance premiums. So what you do is you simply go to the doctor, get the care you need. That doctor, she orders a test, you don't have pre-authorization. You get the test based upon your doctor's orders, and then when the prescription's ordered, you go to pick it up. I mean, it simplifies the experience, and all this stuff that happens in the background that we know too much of, we know too much, right? We know too much. The difference between a Kaiser and an Aetna. If you think about it, who is my doctor in this network? Oh, what if I change plans and I have a 80% coverage rate, but my deductible is, $200 higher? I mean, it's all this intricacies gone. And so what replaces that is a sense of freedom, because now I don't have to keep a job just for health insurance. I don't have to worry about whether my family's going to get covered, and peace of mind, because I'm not worried about whether I'm actually going to get the care I need.
This question of people staying in jobs to hold on to their employer-provided health care, are there any studies of how widespread that is? You read a lot about it.
I've seen some, but I don't recall off the top of my head. I have seen some, yeah. But it's really, I mean, from an economic point of view, it's an inefficiency, right? Why should I stay at a job that I hate, that I'm not doing very well at? Because for the simple reason that if I leave, I'm no longer insured. And I was uninsured. I was rejected prior to the ACA based on a pre-existing condition. I couldn't get insurance. Kaiser turned me down, and Blue Cross Blue Shield turned me down. This is in the state of California in the early 2000s. And so, of course, I was an independent consultant, and so I found a way to get insurance by by faking my employment with a company of somebody that I know, right? So I became an employee, sort of a ghost employee, and then I paid all of the stuff that they were paying in terms of premiums and et cetera.
Statute of limitations run out on this?
I don't know. But I'm on record now. I'm on record.
The insurance company will retroactively go after you for fraud.
Okay. Well, that was a decade ago. That was more than a decade ago. But
they don't watch our programs.
But anyway, it's not. It basically keeps people, in a kind of indentured servitude in a way. Yeah. But in this case, it's to your insurance policy, right? Right. And it's really not a good thing. It's not good in terms of efficiency. In terms of distributing the talents and interests that people want to do around in a more desirable way, in a more efficient way, would be let people go where they want to go, and having portable insurance.
And if you move from California to Ohio, it's the same plan.
But keep in mind too, some of these alternatives to Medicare for All that we hear about don't solve this problem. Right. Because what they do is they say, well, yeah, your employer can buy into Medicare. You've heard that proposal. Yeah. Well, what if you change jobs and go into an employer who isn't buying into Medicare? Well, all of a sudden you're back into the same game,
problem,
right?
Yeah.
So we have to really understand the impact of this. If we organize our system based upon employment insurance, employer-provided insurance, then inherently you're going to have restrictions in terms of choice, and you're going to have the inefficiencies that Salem talked about.
And essentially that's what we have right now is it's driven by employer-provided insurance.
Exactly.
It's 56 million on...
153 million.
Yeah, it's something like that. Yeah. You hear different numbers, but the reason is because some are quoting the actual number of employees, and some are quoting the employees plus their families who are covered. So sometimes you hear numbers like 180 million, and sometimes you hear a number like 130 million. Well, I think the 130 million is the actual employees, and 180 million is employees plus family members, and so that's important to.
But most employees, many can't afford family coverage, though.
Yeah,
a huge distinction there.
Yeah. Well, I'm going to return to some of these nitty-gritty questions, but in general, under the current plans, and I do want to mention that there's not just one bill in Congress right now. There's several, but generally, what is the plan for getting from where we are right now to Medicare for all? It's obviously something you can't do overnight. If you're getting rid of the private insurance companies, that's a big chunk of our economy to deal with. What's the plan for getting there? How long is this going to take? That sort of thing. Well,
the House bill envisions a 2-year process. HR 1384, and that is shorter than the Senate bill, which has a 4-year transition process. A study that Bob Poland worked on with other researchers at the UMass Amherst Peary Institute there said the ideal transition period is 1 year. And, the ACA was 4 years. Here's the argument, that we found during the ACA that 4 years gives a lot of time for the insurance industry to muck with things, a lot of lies to be told, and a lot of political hay to be made against it. Medicare itself was implemented in 10 months in 1965.
But that wasn't replacing anything. It was kind of added on.
But this isn't really. This is replacing the private insurers. Yeah. But as that study found, you can start raising the revenue and pay providers through the existing Medicare system because every provider is already in the system. Mm-hmm. You don't need to change anything. You basically just say, "Here's your card, everybody. Go to your doctor. They're already in the system." And then all of a sudden you experience directly no copays, no deductibles, no insurance premiums. I argue that as soon as you can experience Medicare for all, you will never want to give it up. So the quicker the transition, the better.
Okay, that's a good point.
But I heard you asking a different question. I heard you asking more like, how does the struggle result in the achievement of Medicare for all?
And no. That is going to be. I'm assuming Congress sometime in 2021 passes something like this.
Right.
How do we?
Well, that's a big if. Yeah, that's a big if.
But politically, there are different strategies we need. Yeah. We're engaged right now in demanding a floor fight in the House. We've gotten 15 senators on S 1129. We've got leading presidential candidates, with the exception of Vice President Biden, supporting Medicare for all. So you've got the political momentum. Second, that's why we were doing the California piece, right? Because California, New York, if they can pass single payer, now we can have shovel-ready single payer in 2021 for a Democratic president to say, yes, California, yes, New York, go forth, show us the way. And that becomes a template for then doing it nationally. And so I do think both of those go in common. The political struggle at the state level. I think Governor Newsom's in a position to do single payer in California. I think we need to move him there and have that ready. And then I also think that the House, we should have a floor vote in the House on this. It's not like
before 2020?
We should have a floor vote by 2020, exactly. And this becomes the defining issue. Let the Republicans, tell Americans, oh, you're on your own for health care. We've got a plan to guarantee it.
Okay. One approach I want to take on this is, I mentioned that I worked for the ballot measure back in 1994. And one of the things I'll never forget is the impact of the Harry and Louise commercials. And the insurance companies are going to be out attacking this plan, whatever it ends up looking like mad, with all this money that they're, that guy who made $66 million will probably...
You mean all of our money?
Yeah, all of our money.
We paid them, right.
So I want to try this. I'm going to go through what I have found to be some of the big attack points in hopes that in your answering this, you're helping these people answer these questions when they talk to their neighbors about it. I want to start with this. You just mentioned some presidential candidates. Well, one of the most recent ones to jump in is Senator Michael Bennet of Colorado, and he was just on CNN a couple of days ago, and he had this to say, quote, "When you tell people the first thing about Medicare for all, either that it takes insurance away from 180 million Americans that have it through their employer, or the taxes we would have to pay to afford that $30 trillion program, that 70% support," they were talking about the polls, and Medicare for all shows about 70% support, that 70% support falls to the mid-30s. I think we need to level with the American people. Level with us.
The U.S. Senate is bought and paid for by the healthcare industry. And so we need to tell the truth to the American people.
That is still going to be the case even if there's a Democratic president in 2021.
That's the problem. I mean,
but that is the problem. But I mean, I just think that's the truth telling.
Yeah.
I mean, and so here's the reality. The private insurance system cannot guarantee us the health care we need. And so what is the alternative, Senator Bennet? We are guaranteeing health care for all. The average family, middle-income family, their costs will go from $10,000 to $900 a year. So Americans will pay less, get more health care, go to the same doctors, and have no barriers to care, no out-of-pocket expenses, no surprise medical bills, and all pre-existing conditions are covered with expanded benefits. So what's your plan?
Yeah. And also, I would respond to Bennett by saying, well, what is your plan for keeping costs in check? If you look at at the existing system that we have, projected 10 years out, you're talking about $50 trillion in expenditures between now and 2028, assuming 10% of the population is not insured. In other words, like what we have now. If you look at the statistics from the Centers for Medicare and Medicaid, they'll tell you that the 10-year projection out to 2028 is a $50 trillion bill, basically. And so what's Bennett's alternative? How do you reduce that? Every single report, even the most hostile anti-Medicare for all studies that have been done on this, show significant savings over, as opposed to that $50 trillion 10-year bill, significant savings with almost any Medicare program or plan that we apply, there are savings. And even the most hostile right-wing conservative think tanks who've studied this tell you that there's a significant savings. And so Bennett is the one who has to answer to the American people.
I thought you guys would love that question.
Yeah.
Talk for a minute about an individual. They're going to be told their taxes are going to go way up, among other things. You just mentioned they'll go from putting out $10,000 a year on healthcare to 900 or something. But there's still going to be a Medicare deduction in the paycheck that it will probably go up. Talk about kind of the numbers that individuals need to be thinking about and looking at.
Well, on average, when we looked at this through the study I mentioned earlier, your average middle income, working class family saves around 9 or 10%. Businesses it's possible to fund improved Medicare for all without a middle class tax increase, because there are a number of broad-based taxes. There's one, a gross receipts tax, which is a kind of tax that many states already levy. There are also upper income taxes, taxing capital gains like wages, for example, produces hundreds of billions of dollars in revenue. So there are lots of ways to do it. What we have to understand is that when you eliminate premiums, deductibles, and copays and finance this through a public taxation, you save tremendous amounts of money, and individuals pay a huge amount less. There are three ways to finance healthcare. We can pay for it directly ourselves, individually. We can subsidize it. And individual, I mean employers or individuals. Yeah. You can subsidize it with taxes in some combination, or you can have the government pay directly, providers. Mm-hmm. That's the most efficient. That's the most equitable.
It's a question of how you divide up the basket, right? The funds are going to be expended on Medicare, on healthcare, I should say.
Right.
Yeah.
The question is, what portion of that is coming from an individual household, individual businesses, or government entities? And if you pool the resources, increase the buying power of the single payer, or of the you end up paying less and being more efficient administratively. That's where you get the main gains, basically, is eliminating all of these. You go into a doctor's office or a dentist's office, and there's a person there who's dedicated to calling insurance companies and asking whether or not this person who has this insurance policy would be covered if we do X, Y, or Z procedure, right? Why would you need such a person? You won't need such a person. That's just the level of a single doctor's office or a dentist's office. Just think about a hospital administration, or a private hospital, or other providers, how much administrative funds, resources they have to put into their operations. All that would be eliminated, and all of those savings would end up being accumulated into a central buying power, buying entity that can then negotiate prices with all these providers for much less than what we're paying now.
Okay, here's another one that I've come across. Michael, you mentioned earlier that the things like Medicare Advantage are huge advantages for the insurance companies, because that's where they make some money. But apparently, and correct me if I'm wrong, but apparently insurance payments to hospitals are higher than Medicare reimbursements. A guy named Chip Kahn, CEO of the Federation of American Hospitals, uses the term Medicare payment for all would put us in a position where the numbers just wouldn't work for us to provide the services that people expect. And from my reading, this seems like an acutely critical problem, especially for rural hospitals and clinics, that they're already struggling financially, and if their reimbursement rate goes down, they may be going down, and just...
It's just the opposite, Paul.
Then
it's just the opposite. The rural hospitals can't survive under the current system because the reimbursement rates that they get, right, from the private entities are not sufficient. There aren't enough people with that private insurance in a lot of these rural areas, so they're not getting enough of those payers. The only thing that's keeping them open is Medicaid, and the states that haven't expanded Medicaid are the ones where the rural hospitals are closing. It's the withdrawal of the public program that's causing hospital closures, like in the state of Texas. There's like over a dozen hospitals closed because they haven't expanded Medicaid. So that's number one. Number two, just as Salem was saying, those hospitals have to pay those billing departments. So what the insurers do is they say, okay, we'll pay you 50, 60% above Medicare. But then you're going to have to employ an entire staff of 20 people to get everything pre-authorized and to get paid, right? So you eliminate both sides of the equation, and it equalizes out to a much less expensive proposition.
Yeah, I should add that House Resolution 1384, the Medicare for All Act of 2019, calls for global budgeting for hospitals across the board. That is to say, the paying entity, the federal government, would apportion a budget to every single hospital on the basis of its expenditures over the last 3 or 4 years, and say, here's your global budget. This is what you, more or less what you've been spending, or what it's costed you to operate over the last 3 or 4 years. Here's that budget. Deal with it. And so you're not going to be nickel and diming people as you come in. Your physicians and your nurses will be paid not on patient by patient, but like Kaiser. Kaiser, I guess, from what I hear, physicians earn $250,000, let's say, right? Something like that, right? $250,000 per year per person. And so they're not paid by the number of people that they see or the number of procedures they do. They have a salary, and then they go about their business. And of course, Kaiser tries to regiment that, of course. My doctor comes and says, look, I've got 20 minutes. That's all I got to spend with you. She actually says that to me, right? I've only got 20 minutes to spend with you. So let's make it quick.
That's how it plays out.
Yeah, that's how it plays out. Yeah. But they do have fixed, a fixed salary. And all hospitals would have that global budget. At least that's my understanding. I may be wrong about that.
No, you're exactly right. Yeah. And here's the point, is that what Mr. Khan didn't say is that these hospitals charge 200 to 300% of their costs. And they do that in order to negotiate with the insurance companies and get a higher reimbursement rate. That takes money and time. It's eliminated. And so when we have a process where everyone's in one system, then you can actually identify the outliers and not have to go through all the machinations that are currently done in order to make sure that we're not defrauded or someone's not being overpaid. We're able to monitor that in the system because everybody's in, nobody's out. And the hospitals, it's very disingenuous what the hospitals are saying, because they know that without Medicare and Medicaid, they don't exist. That's actually the foundation of their business. That's how they paid for all those fancy machines.
Yeah. All right. One more. We're going to be hearing, I suspect, and from a lot of the Democrats who are a little skittish about Medicare for all. Not everybody has signed onto the bill yet. The so-called public option, which is the public option would be allowing people to buy into Medicare starting at some age in their 50s. Now, it sounds like a very reasonable, cautious approach, and it would kind of strengthen the ACA. The public option is something that a lot of people were demanding when the ACA was, so what's your response to the people that say, let's do this, let's have the public option, fix and strengthen the ACA and with the public option, and we'll be good. People are liking ACA now.
Well, 50% of the people sort of like the ACA. It doesn't poll as well as Medicare for all. But the truth of the public option is that Medicare is not just another individual insurance plan. It's a social insurance system that all the advantages that we've been talking about here tonight derive from the fact that everybody's in one system. You can create a public insurance plan. If it mimics the private insurance plans, why is it better? If it doesn't mimic the private insurance plans and everyone joins it, how does it survive financially? It's a setup. It's a bailout for the insurers, because what you do is you take the really high needs patients, put them on the public plan, then all the healthy people are left for the private insurers. I guarantee you they will find a cheaper.
You clean up their pool.
You clean up their pool, exactly.
You're reducing their risk pool. You take all the people who basically
they can't cover profitably.
It's the classic moral hazard problem in economics, right?
That
the sickest people will sign on to the public option. The ones who need the greatest needs, and that'll be the burden on the public, whereas they get a nice,
and then guess what happens?
Clean pool for the private insurers.
And the public plan then fails. Oh, look at this!
Exactly.
Government can't do it.
The
insurers are out there making money hand over fist because they got all the healthy people.
Yeah, but it's just like car insurance, right? The people who drive terribly, cause all the accidents, cause my premium to go up as well. But we're in such a large pool that we pool the risk.
Not that ill health is anyone's fault.
Right, precisely, right. But
our health is not a risk.
Of course not. Yeah, but I mean, you learn this in basic economics. I mean, you used to teach. The larger the pool, the lower the risk per head.
Yes, yeah.
Per head, basically. Whereas when you break up the pool as we do, this fragmented system, right? You don't know in this pool if you've got people who are going to prone to develop cancer, right? And therefore to be very, very expensive over the long term, versus a group that will have no problems. So you don't know. So the best pool, the most efficient pool, the best pool is everybody in, nobody out, basically.
Otherwise, you're underwriting, and the insurance function will then leave people out.
Yeah. I've got lots more questions, but let's see if we have any from our audience here. Who's doing the mic tonight? Julia is going to do it. So just raise your hand, and Julia will find you. And why don't we start right here? And if you would stand up and make it easier on our camera people. They don't like to work too hard. Hold it right up there.
Thank you. My mother, 91 years young, and her social group is against Medicare for all because there won't be enough doctors to handle everybody that will go into the system. And I would think that there's probably an awful lot of maybe the most senior people in our country that might feel that way, but I haven't heard you address that issue.
Well, go ahead. Oh. Okay. Well, the way I address that is saying that's what they were saying about the ACA, about Obamacare. We're going to have this surge of people insured that weren't insured before, and the system will collapse. Well, we got I think there's 30 million now insured under ACA, and there's 30 million uninsured out there in the United States. So did the system collapse with those 30 million? It did not collapse. It actually did quite well for the insurance companies, and probably for lots of healthcare providers as well, to have 30 million more customers, paying customers that weren't paying before. So number one. Number two, of course, there's going to be some adjustment. Without a question, there'll be some adjustment period, because not only will you have 30 million uninsured now in the pool, but people who are underinsured, the 44 million, the 45 million who are underinsured, who stay away because of the high deductibles, will seek care now. But all the studies show that the increased care over after the introduction of an expansion in medical services results over the long term in a more healthy population and lower costs over time, so that people catch things early on and don't put it off. And so over time, you're doing what the healthcare system should be doing, is making people healthy, right, over time. There's adjustment. Yeah.
Right, but we have quantified this specifically, that again in that Peary study, we estimate about 12% increase in use. And that can be accommodated by the existing workforce. What we have to keep in mind is that the pending doctor shortage exists whether we have the current system or a new system. And that's what we found last year when we were debating the SB 562, is people say, well, what about the physician shortage? And I said, well, what about the physician shortage now? What are you doing about it? And in fact, when we have one system, we are in a better position to allocate those physician resources. What we found is that when physicians go into a Medicare for All system, they won't be spending all that time collecting money. They won't be spending all that time on billing and pre-authorization administration. That is between 8.7 and 11 hours a month of time that they spend on those, or a week actually, I think that's actually a week, 8.7 hours a week. So what we do is we turn those into clinical hours. They can take the increased patients, and they can keep their salaries up, because even though the rates might be slightly lower, they'll see more patients because they're not getting paid for the time they're on the phone with the insurance companies, but they will get paid when they see a patient. So you can keep physician income up, you can expand the available clinical hours, and save the money administratively.
All right. Can you give her back the mic for just a sec? Because I want to ask, are you going to be able to take that to your 92-year-old mother now and explain it?
I'll explain it that way. Whether she understands it is another question.
Okay, I think I saw a hand in the back there, Julia, and
Mr. Lighty just answered the question I was going to say. That
take the mic, take the mic.
Mr. Lighty just gave a comment that answered or said what I was going to say, was the fact that the medical professionals are spending a huge amount of time answering resistance questions from the private insurance companies. So all that time that they're wasting talking and justifying their diagnosis and prescriptions will be going away. So they have more time to really be profitable.
Okay, excellent comment. All right, back up front here.
Hi, I'm Joan Simon from the Santa Clara County Single Payer Healthcare Coalition, and I have a question that is from my friend Sumitra Droy, who is a longtime single payer advocate from Palo Alto. Unfortunately, she could not make it to the meeting. She is homebound, and she has the following question. It is her understanding that Bonnie Castillo and the National Nurses Union came out in the fall of 2018 opposed to Section 611B and ACOs, Accountable Care Organizations, in the Medicare for All bill. And we're going to lobby Bernie to ask that he remove them from the bill. Did that happen? And if so, why is Section 611B and the ACOs still in Bernie's bill? What was Bernie's rationale for leaving the ACOs in the bill? Thank you.
And I would ask you to explain what an ACO is first.
Right. I definitely cannot speak to what Bonnie Castillo did, so I have no comment on that. What ACOs are, they're accountable care organizations. Those are essentially HMOs. And so what they're trying to do with the Affordable Care Act is, one of the theories they had was, let's put insurance companies together with hospitals and doctors and clinics and create these entities where what we were earlier talking about in terms of global budgeting, you could just give that entity $100 per person in that system, and then all the care that they get will be covered within that system. So that's very attractive. People like the Kaiser model. They like that. And so it is somewhat popular among Senate Democrats. It's a big political problem we have because these Medicare Advantage plans people like because they have better benefits and they have the drugs included and it's easier, right? Only when they find out their specialist is, 50, 100 miles away does it become a problem. So the accountable care organizations are trying to create essentially a closed network, right, that people get all their care in and paid for on a per person basis so it's more efficient. We can take that on, we need to take that on because it has real problems. The global budget works for us, but this particular configuration looks like it is incentive to deny care. Because any system like this means if I'm only getting $100 per person, I need to only spend $50 on some people because some people I'm going to spend $150 on. So I better make sure that I only spend $50 on a lot of people. Well, that means you're going to deny care. And so you have to balance that. And that's the problem with the ACOs. And that's the problem that they're still in 1129. We've got some work to do. But don't underestimate the political problem we have with these Senate Democrats who are bought into this for-profit HMO private insurance system. And ultimately, that's the fight we have.
And just a sec, I just want to follow up on, we've mentioned the numbers a couple of times, and for people who are keeping score at home, in the Senate, Bernie Sanders' bill is S 1129, and in the House, Congresswoman Jayapal's bill is HR 1384. These are not
technically Jayapal Dingell, because Debbie Dingell is the official co-author.
Oh, that's right. Okay. These are not identical bills,
No.
but very similar.
Yeah.
Okay, to the audience.
Thanks so much.
Yeah.
Thanks so much. I'd actually like to just add a note to Veronica's question, which was that we are the only country on the planet that has 2/3 specialists and 1/3 primary care physicians, and it's the primary care physicians that are incredibly in short supply. Every other country in the world has the reverse ratio, 2/3 primary care physicians. They also have much better healthcare outcomes than we do, which many people think is partially a function of following a patient all the way through rather than as quickly as possible handing them off in that 15 or 20 minutes to a specialist. The AMA puts their specialists on the congressional committees that set the rates of reimbursement. And that's another reason that our costs for physicians have gone sky high. Kaiser is opening a new medical facility, a new arena in which to train more doctors. We need more of that to happen. But in going to a single payer system, Congress can then wake up to who should be on those committees setting rates. And reimbursements will be much more fair among physicians. More medical students will be interested in going into primary care again, thank heavens. And I think that imbalance will even out.
Yeah, I just make one comment on that, and that is that's exactly right. That our system is lopsided with specialists. Those specialists, by the way, give lots of money to lobbyists to give to politicians. In particular, the head of the Ways and Means Committee, Neil of Massachusetts, the Democrat, is a top 20 all-time recipient of doctors, lobbyists, funds, money. That means going back 30 years and covering 1,800 different members of Congress. He's a top 20 recipient of specialists, basically, lobbying money. And he's the head of the Ways and Means Committee, so he's a gatekeeper, basically. Yeah. So that's just one thing to keep in mind. And then, secondly, what I would say is, if you've got a handle and a single payer on the system, not only do you have monopsony power, but you also have the access to big data in real time about what's happening in the country and what's needed in the country. And I can't imagine over the long term that we would be graduating physicians with $250,000 in debt in the long term if we have a single payer system, right? And if you eliminate that, New York University, by the way, recently, if anybody saw 60 Minutes a couple of weeks ago, has made medical school tuition free. So if they accept you into the medical school at New York University, you graduate with no debt. That has immediately caused people that they interviewed in the program on 60 Minutes to say, we're going to be specializing in family medicine and in primary care medicine, and to do the things that we want to do rather than having to do the things that we have to do to pay back the debts that we graduate with. You follow? And so over time, part of the health policy must be to make medical school, like everywhere else in the world, a free or at least heavily publicly subsidized, so that doctors are not, physicians don't graduate with all that debt and have the need to go out and milk everybody,
We've got about 10 minutes left. Let's talk about the political, how do we get there from here, which you thought I was talking about earlier, but okay. I thought I'd save the best for last. Okay. And just what are some of the strategies that you're looking at? This is a big issue. It's going to take a lot of educational stuff like this. You're going to be up against insurance company money on television every evening. They've already started forming various coalitions and stuff to fight back about this. So, politically, what's the struggle look like over the next year or two?
Well, I think there are a couple of things that are vitally important. Number one, anyone like Senator Bennett, who wants to make those criticisms of Medicare for All, needs to defend the current system that pays the CEO $66 million, that denies 200 million claims a year, that creates $35 billion in profits last year. Why is that system okay? And if you are a defender of the present system, then that's what you're defending. We can solve this problem one issue at a time politically. What is a pre-existing condition? That's simply the fact that we haven't gotten the health care we need. 2/3 of Americans have a pre-existing condition, 2 or more, by the age of 65. we can try to solve these one issue at a time. What's a surprise medical bill? A surprise medical bill is simply the fact that I went outside of my network and got care. But a surprise medical bill is a result of the policies established under the ACA, and now they say they want to fix the ACA, but they're fixing something that's inherent to that model. So you have to change the model. Politically, how do we do that? I mentioned it earlier. We've got to win in a big state. We've got to push the floor fight. We've got to have a corporate campaign against these insurance companies so the politicians who are fronting for them are exposed. We're talking about, we're barnstorming. We're barnstorming in Representative Neal's district practically every week. They're canvassing in his district, and they've announced they're going to do a hearing at Ways and Means. We don't have a date yet, right? That's not going to be sufficient, but it's obviously necessary. I think the bottom line, Paul, is leadership. Leadership that is strategic, that is relentless, and operates at all levels. So in the Santa Clara Valley, we have leadership to the Single Payer Coalition. I think we need leadership at the presidential level. I've been trying to do this like you. I worked on Prop 186 in 94, worked against Hillary Care for single payer in 92, 93, 94. What we lack is Democratic unity, and we've still got Democrats who are not on board with Medicare for all, including the Speaker of the House. It's not the power of the insurance industry that's the problem. Our problem is a lack of unity on our side to demand the reform that we know that works and is popular. And that unity requires leadership, and it requires a president who's going to be relentless and committed to this. I think the only candidate in the race now is Bernie Sanders, who will be sufficiently committed. But it takes that kind of strategic, committed leadership at all levels as part of this broad mass movement. We're only going to win this if it's a mass mobilization. I think we've won the policy fight, frankly. Well, and I think, because as you said, the conservative economists who study it say single payer saves money. Sure. All right, so what's the fight about? Yeah. The fight is about the political power of that industry, and it requires unity on our side to beat them.
Yeah, I'd take a different, slightly different approach, and I would say addiction to lobbyist money is a pre-existing condition, and Obamacare is not going to take care of it, right? It's not going to take care of that pre-existing condition, basically, because Obamacare is in large part the results of lobbyist money. And I say that sort of half jokingly, but it's true.
I think everybody's aware. It was an immense
I would just like to
compromise.
to just say that I cannot imagine us winning. And if we're in this fight to win, I can't imagine that we can win without taking down certain strategic incumbent Democrats who are gatekeepers and blocking progress. And I would just point to the example of New York State in the last round of elections, where they took down 6 of 8 incumbent conservative Democrats who were organized in something called the Independent Democratic Caucus, which was giving effectively Republicans control of the Senate, even though people with blue and D's behind their names were a majority in the New York State Senate and in the New York State Assembly. And the governor. They have a trifecta, which is what we have in California. But ours is a supermajority veto-proof trifecta. We have a Democratic governor, supermajorities in the Senate, supermajority in the Assembly. We have the highest poverty rate of any state in the United States, and the highest poverty head count of any state in the United States. This is a blue state, and it's a poor state. We also happen to be the biggest frackin' state of all states, right? More than Texas, more than North Dakota, more than Oklahoma. All of this under the aegis of Democrats. So unless you take down Ocasio-Cortez, again, is proof of concept. What we need is scale. What we need is a replication of something like that on the West Coast, where we have a border-to-border trifecta. Oregon, Washington, California, majority Democrats in all houses, majority, all governors, Democrats. We're still not getting single payer passed in the state of California, in the bluest of states. So until you take down certain set examples that you can take down incumbent Democrats who are blocking, showing what they've done in New York, they're closer in New York now as a result of taking down incumbent Democrats.
Well, that to me sounds not unreasonable, but also a much longer term kind of thing. Addressing Medicare for all, which is an issue on the table right now with these Democrats in Congress. For example, what sort of grassroots things is the Single Payer Coalition doing? You've done the barnstorming.
Sure.
You're going to continue that on Medicare for all?
We met with our representatives. You yourself organized, and thank you very much for organizing the meeting with Congresswoman Eshoo several weeks ago. Several people in the audience, and you and myself and others were there, and it was very useful for her to hear from us. But Eshoo is one of the problems.
Yeah.
You know, yeah, she's one of the problems. But
It's
anyway.
unlike Ro Khanna, who's one of our champions.
Sure.
Yeah.
Just to say.
Yeah.
I mean, he's going around the country
And to be fair, seven out of 10 Bay Area Democrats in the Congress and the House of Representatives are on board. 7 out of 10. It's just Pelosi, Eshoo, and Zoe Lofgren who are not.
Yeah.
In the Bay Area.
We're almost out of time, but one thing I've read about, and I think your group is going to be working on this, is for local activists, you're going to be trying to get resolutions from city councils and things like that. Speak very briefly to that. We're really down to a couple minutes.
There is a national campaign now through National Nurses United, I believe, and other organizations to get municipalities, county governments, and other local governments, entities, to come out and support resolutions in favor of Medicare for all as a way of showing the groundswell of support. There is a groundswell of support. There's no question about it,
Yeah.
and that's really what gives us our momentum going forward. But certain other things have to be done. But I think that's one excellent way to do it, is to show that local governments are for this.
Well, the truth is local governments have a lot to gain. We did a study in Florida and just looked at what school districts could save versus what they're paying now for health benefits for teachers and other workers versus what they would pay, say, under like SB 562. $700 million a year savings. The people who have the most at stake in this debate at the state level are teachers and students and parents, because once we free all these resources, California's got an $80 billion retiree health liability. We wipe it out if we do single payer. That's money for education. This is what's
It's a good argument.
This is what's at stake.
It's a very good argument. You've got 30 seconds. Wrap this up for us.
This is our moment. We've never been closer. And I think what's happening is that people finally realize, I can experience peace of mind. I can get the health care we need if we act collectively to win Medicare for all. So there's not a better time to be engaged in this fight.
Not a better time to have these two gentlemen on either, Michael Lighty and Salem Ajluni. You've been watching Other Voices, brought to you by Peninsula Peace and Justice Center. We're in here on the first Tuesday of every month. Gentlemen, thanks.
Thank you so much, Paul.
Thank you, Paul.
Thank you all.
Great job. Great job.